The main job of an ear is to sit on the side of the head and not draw attention to itself, remarked Mobley in the preface he wrote for an edition of the Facial Plastic Surgery Clinics of North America. The helix is the most prominent part of the external ear, visible when viewing the face from the front and even more conspicuous in profile. Defects involving both the helical rim and posterior ear represent a unique reconstructive challenge. The rim of the ear is curved, whereas the skin on the anterior ear is closely adherent to the cartilage and cannot be moved to cover the defect. For defects of less than 2.5 cm in width, several options exist, including wedge resection or antia-buck helical chondrocutaneous advancement flaps. For larger defects greater than 2 cm in size, staged procedures have been traditionally used for reconstruction. Conversa's tunnel technique is a two-staged procedure. In the initial stage, an auricular cartilage graft taken from the contralateral ear is tunneled under the postauricular skin adjacent to the helical rim defect. The second stage is performed 3 weeks later, by taking the anteriorly based skin flap along with the cartilage graft and insetting it into the helical rim defect. An alternative two-stage procedure is Dieffenbach's flap, which involves harvesting contralateral auricular cartilage and suturing it to the helical rim defect, then elevating postauricular skin, and advancing and covering the cartilage graft. The pedicle is subsequently divided at 3 weeks and inset. Alternatively, tubed bipedicled flaps may be used and are typically staged over 3 procedures. However, a single-stage helical rim reconstruction using a postauricular bipedicled flap technique has been described. The Eave skin flap was devised primarily for isolated defects of the helix. It can be used to reconstruct the entire helix or a portion of it in a two-stage procedure. It uses the postauricular and mastoid skin, which is a good match for the skin of the ear. The flap donor site scar or skin graft is concealed behind the ear. An Eave flap can restore the sharp delineation of the helix. The Eave flap is not advised when the ear framework is of alloplastic material. The procedure is based on the observation that a skin flap that is dissected free and held at both ends will curl until it spontaneously tubes itself. This curling is caused by the contracture of the denuded undersurface of the flap. If half the width of the flap is inserted into the tissue and the other half is unattached, the latter will curl until its undersurface becomes completely epithelialized. By pressing the auricle against the mastoid, the length of the flap is outlined, and an incision is made a few millimeters posteriorly. At both ends of this incision, perpendicular divergent incisions are made, thus widening the flap as it extends posteriorly. The anterior margin of the postauricular incision is approximated to the posterior edge of the helical defect, which forms a skin-line tunnel and also bends the auricle backward, holding it in close approximation to the mastoid. The incised mastoid skin flap is undermined for a distance of about 3 cm. Its anterior free margin then can easily overlap the margin of the auricle. The upper and lower corners of the flap are sutured into the open incisions along the margin of the defect. 3 or 4 double-armed nylon sutures are inserted into the anterior lip of the helical defect, pass through the flap, then tied over bolsters about 2.5 cm posterior to the free margin of the flap. The sutures control the amount of overlapping. Within 3 weeks, the undersurface of the overlap is epithelialized, and there is a noticeable curling of the anterior border of the flap. The second stage is usually carried out 3 weeks later. The necessary width of the flap is estimated, and the flap is cut free from the mastoid. The posterior border of the flap then is trimmed as needed and sutured to the remaining skin on the medial surface of the auricle. The mastoid defect can be closed by advancing scalp skin, although a skin graft is usually used. 26 years male, victim of human bite right ear, with full-thickness skin loss of around 2/3 of right helix and scaphoid fossa. By pressing the auricle against the mastoid, the length of the flap is outlined, and an incision is made a few millimeters posteriorly. At both ends of this incision, perpendicular divergent incisions are made, thus widening the flap as it extends posteriorly. The upper incision is about 2.5 centimeters long, and the lower is considerably shorter. The latter can be dispensed with if the lower pole of the flap extends below the middle of the auricle where the helix is flat. These incisions outline the mastoid skin flap. The anterior margin of the postauricular incision is approximated to the posterior edge of the denuded helical defect, which forms a skin-line tunnel and also bends the auricle backward, holding it in close approximation to the mastoid. The suturing is done with fine catgut or dexin, knotted on the skin surface inside the tunnel. The incised mastoid skin flap is undermined for a distance of about 3 centimeters. Its anterior free margin then can easily overlap the margin of the auricle. The overlapping must be free of any tension, or the flap will retract and flatten during the healing period. The upper and lower corners of the flap are sutured into the open incisions along the margin of the defect. The anterior margin of the mastoid skin flap, the Eave flap, overlaps the scaphoid surface for a distance of 3 to 6 millimeters. More overlap is allowed in the upper portion to obtain the effect of tapering off. 3 or 4 double-armed nylon sutures are inserted into the anterior lip of the helical defect and passed through the flap. They then are tied over bolsters about 2.5 centimeters posterior to the free margin of the flap. The sutures control the amount of overlapping. Packing is inserted into the postauricular skin tunnel and underneath the overlap. Within 3 weeks, the undersurface of the overlap is epithelialized, and there is a noticeable curling of the anterior border of the flap. The second stage is usually carried out 3 weeks later. The necessary width of the flap is estimated, and the flap is cut free from the mastoid. The skin-line tunnel is incised, allowing the pinna to return to its normal position. The posterior border of the flap then is trimmed as needed and sutured to the remaining skin on the medial surface of the auricle. The mastoid defect can be closed by advancing scalp skin, although a skin graft is usually used. The curling effect of the thin mastoid or auricular skin gives an excellent simulation of the normal helix. If the helical flap includes scalp skin or a skin graft, however, the result is usually less satisfactory because the reconstructed helix is thicker, bulkier, and curls irregularly. The Eave skin flap can be used to recreate the helical rim by taking advantage of the natural tendency of the free edge of a flap to curl. Postauricular flaps used in ear reconstruction can be based in the superior, middle, or inferior postauricular and mastoid region. In the literature, various surgical techniques relating to helical rim reconstruction have been discussed. The ideal reconstructive procedure should be easy to perform, necessitate a single surgical stage, provide good aesthetic results in terms of color match and texture with minimal visible scarring, and No significant donor site morbidity.